So we finally made it down to the lower gastrointestinal tract to talk about some disorders. So the problem with a class like this is you start reading all these symptoms and then you go, wow, my stomach kind of hurts and I haven't been hungry all day. Oh no, maybe I have peritonitis. That's it. It's a tumor, or something like that. But obviously there are a lot of these symptoms that are common throughout the digestive system disorders, and differential diagnosis is what the doctors have to do in order to figure out what you really have. So we're going to start at the top and work our way down. So celiac disease, it's a malabsorption syndrome. It started out as being primarily a childhood disorder, but it can occur in adults in middle age, whatever that means. Usually it's in your 30s or 40s, and it appears to have a genetic link. A lot of people who have English descent are more prone to celiac disease. There's that genetic link. It's a defect in an intestinal enzyme that prevents further breakdown of gliadin, which is a breakdown product of gluten. So it has a toxic effect on the intestinal villi, an atrophy of the villi, and so you end up with malabsorption and malnutrition. A lot of times with children, the first signs appear when they are starting to get weaned at 4 to 6 months of age, and their parents are adding cereals into their diet. The manifestations, and usually it's wheat products, there are other products that have gluten in it, but wheat products are high in gluten. What you see with children is fatty bowel movements, steatorrhea, muscle wasting, failure to gain weight, irritability, and malaise is common. For adults, where it occurs later in middle age, sometimes it can be an autoimmune disorder. It still has that genetic link, so the intestinal villi are actually getting broken down because of the autoimmune reaction, and it's gluten that spurs the autoimmune reaction. So it's diagnosed with a series of blood tests. A lot of times with adults, the symptoms that they get are they have intestinal distress, irritability and malaise, and sometimes they have anxiety associated with it, and it just might be because of the intestinal distress is causing them anxiety. The treatment of celiac disease is a gluten-free diet. The intestinal mucosa heals and returns back to normal after a few weeks without gluten intake. So gluten is the irritant that causes the problem. So you can have other gluten intolerances when and it's more of a type 1 hypersensitivity reaction, like an allergic reaction, which is separate from celiac. So people that have celiac disease really should avoid gluten in any form. People that have the type 1 sensitivity reaction can sometimes eat a little bit of gluten, but they just can't eat it a lot, if that makes sense. So luckily, gluten-free products are a lot more available, especially if you live in Bellingham, which is sort of like a gluten-free haven. A lot of restaurants have gluten-free choices and that sort of thing. But people I know who have celiac, they say once you get used to eating that way, it's no big. It's really easy to do. I think it's a little harder for children. Separate cooking surfaces are important. Like if you had 2 children, one had celiac and the other one didn't, you wouldn't want to make wheat toast in a toaster and then make the child with celiac's gluten-free bread toast in the same toaster, because you could get cross-contamination. So once you get used to it, that gluten-free diet thing, though, it's pretty easy. Chronic inflammatory bowel disease is a sort of an umbrella term that covers a lot of different things. Crohn's disease, ulcerative colitis are included. There are also other chronic inflammatory bowel diseases included under that umbrella. It's not really known what causes Crohn's and UC, but again, like with a lot of things, a genetic factor appears to be involved. Crohn's disease often develops during adolescence, and ulcerative colitis is usually in your 20s or 30s. So there are a lot of similarities in the symptoms between Crohn's and UC. So this is the little chart from the book. You know, I like the charts from the book. The main difference between Crohn's and ulcerative colitis are what areas are affected. In Crohn's, it tends to be the end of the ileum and sometimes the first part of the colon. In UC, it tends to be the colon and rectum. So, and then the layers that are affected and the characteristic stools. So, Crohn's disease and ulcerative colitis can be really sort of debilitating diseases in that they can really disrupt your life. So with Crohn's, you get the malabsorption and malnutrition, and that can affect your energy levels. It can affect your work, and it can affect a lot of things. You'll see, I always watch the drug ads on TV. I don't know why, but I fast forward through most commercials. But there's something about those drug ads that maybe I want to stay informed about what drugs are out there. But you see now that they're treating Crohn's and UC with immunosuppressant drugs. So that leads me to believe that there is some immune system factor. But anyway, with Crohn's disease, it can affect any area of the digestive tract, but usually the small intestine is affected. So the small intestine, that's the biggest area for absorption of nutrients, right? So you can get that malnutrition, malabsorption factor going on. The inflammation occurs in a characteristic distribution. They call them skip lesions. So it's affected areas separated by areas of normal tissue. So the inflammation skips areas. That's why they call it a skip lesion. Progressive inflammation and fibrosis can cause obstructions. Damaged walls impair processing and absorption of food, and inflammation stimulates intestinal motility, causing irritable bowel type symptoms. The interference with digestion and absorption, you get low protein in your blood, you get avitaminosis, which means you're not absorbing vitamins, malnutrition, and possibly those fatty bowel movements, steatorrhea. Other complications, because of the breakdown and fibrosis of the tissue, you can get adhesions between the loops, and you can get fistula. And a fistula in the body is any place where there's an opening between two things that ought not to be connected. So you can get a fistula between the colon and the small intestine, or a fistula between the colon and the peritoneal space, which that can cause problems too. Untreated Crohn's disease in children can cause delayed growth and delayed sexual maturation because of the malnutrition aspect of it. A lot of times they use glucocorticoids for that inflammation, and now they're starting to use the immunosuppressant drugs. So this is a little thing showing those skip lesions in Crohn's disease, and some of the breakdown in the formation of a fistula from the book, of course. With UC, the inflammation starts in the rectum and progresses through the colon. So with Crohn's, it's starting from the small intestine and progressing to the colon. The ulcerative colitis is starting the rectum and progressing through the colon. And it's the mucosa and submucosa that are inflamed. So you're not going to get the fistulas like you do with Crohn's, but there is tissue destruction that interferes with the absorption of fluid and electrolytes in the colon. So if you have a lot of acute episodes of ulcerative colitis, you can get a condition that's called toxic megacolon. So lots of diarrhea containing blood and mucus accompanied by cramping pain. That sounds unpleasant, doesn't it? So here's some poor person's acute ulcerative colitis, and you can see it's messed up in there. Not a pretty picture. So treatment of inflammatory bowel disease, whether it's Crohn's or ulcerative colitis, they say it's a team approach. So a lot of different drugs are used, anti-inflammatory medications, anti-motility agents to reduce the motility, nutritional supplements to counteract the malabsorption, antimicrobials, because anytime you have tissue death and inflammation, that just opens a door for those opportunistic pathogens. Immunotherapeutic agents, like I was talking about earlier, and surgical resection, and either an ileostomy or colostomy, where basically they take out the, they open up a hole in the ileum or the colon, and the lower part's not being used, and you have an external bag for your waste products. Irritable bowel syndrome. There are lots of different types of it. It can be caused by abnormal gastrointestinal mobility and secretion, visceral hypersensitivity, post-infectious, so after an infection, the bowel's just more irritable, overgrowth of flora, food allergies or intolerances, or psychosocial factors. So lots of things can cause irritable bowel syndrome. The manifestations are the same, though, despite the cause. Lower abdominal pain and cramping, diarrhea, constipation alternating with diarrhea, so you have the worst of both worlds, bloating and nausea. Usually it's diagnosed based on signs and symptoms. They usually test for food allergies, they'll test for bacterial or parasitic infections, they'll do stool samples for the testing. There's no single cure because it depends on the cause. So the cure is going to vary depending with the cause. So sometimes it's just, you just really have to stop eating at that restaurant that's across the street from where you work. Appendicitis, very common. It's obstruction of the appendiceal lumen caused by a fecalith, gallstone, or other foreign material. So fecalith is like a buildup of fecal matter. The fluid builds up inside the appendix, and the microorganisms are having a party. It's a microorganism party, and so you get itis, get inflammation. Purulent exudate, that's an excellent sign of bacterial infection. Forms in the appendix is swollen. You can get ischemia and necrosis of the wall, which results in increased permeability. So bacteria and toxins then can escape into the surrounding area. It can lead to abscess formation or localized bacterial peritonitis. There's that peritonitis again. You can develop an abscess if the inflamed area is walled off, and the inflammation and pain can temporarily subside. Localized infection or peritonitis develops around the appendix, and it can spread along the peritoneal membranes. So there can be different levels of effects depending on the progression of the illness. So you get increased necrosis and possibly gangrene in the wall of the appendix caused by increasing pressure in the appendix, and then the appendix can rupture or perforate, releasing the infectious contents in the peritoneal cavity. So you get generalized peritonitis, and it can be life-threatening. The treatment for all that stuff is remove the appendix surgically and antimicrobial drugs. So sometimes in the course of other gastrointestinal surgeries, they will, even if the appendix is not inflamed, they will routinely remove the appendix just to prevent problems in the future. Kind of interesting. So typical progression of pain in acute appendicitis, you get pain around the umbilicus, periumbilical pain, increasing in severity as the inflamed appendix is distended. You can get localized severe lower right quadrant pain, deep localized tenderness on palpation. The pain usually decreases with the rupture because it doesn't have the pressure on those on the nerve endings in the appendix area. Peritonitis causes severe steady abdominal pain as the infection spreads. So hopefully they get it in the first stage before it gets to the worst parts. Usually it's the second stage that people end up going in for. Periumbilical pain related to the inflammation, nausea and vomiting are common. Pain becoming severe and localized in the lower right quadrant. Lower right, rebound tenderness. That's where when you let go, it hurts more. Involvement of the parietal peritoneum over the appendix. After rupture, the pain subsides temporarily, but then it recurs in a severe generalized abdominal pain and muscle guarding. You can have a low-grade fever and leukocytosis because of the development of inflammation with the peritonitis. That board-like abdomen, that's from somatic stimulation of those abdominal muscles. Tachycardia and hypotension as peritonitis develops. The abdominal wall muscles spasm, and the toxins lead to reduced blood pressure because the toxins increase capillary permeability. So, diverticular disease. Diverticula are little outpouching or herniations of the mucosa through the muscular layer of the colon. Diverticulosis is asymptomatic diverticular disease. So that means osis usually means a condition. Itis usually means inflammation. So diverticulosis means you have the condition of having those little outpouchings. Diverticulitis means those guys are inflamed. It forms at the gaps between muscle layers. Sometimes they think that congenital weakness of the wall of the colon can be a factor because some people are more prone to diverticula than others. Weaker areas bulge when pressure increases. A lot of times you can have diverticulosis that is asymptomatic, and it doesn't become symptomatic until it becomes inflamed. So diverticulitis usually involves stasis of material in the diverticula leading to inflammation and infection. So you can have from the infection you can have a slight fever and an elevated white blood cell count, and then you can have cramping, tenderness, nausea, and vomiting. It's often treated with antimicrobial drugs to take care of the infection and dietary modifications to prevent stasis in those diverticula. So the type of dietary modifications that you'll see is you're going to avoid high fiber foods, you're going to avoid things with seeds. It's kind of like a bland diet. And then once it heals, once you get out of the itis stage, then they want you to eat a high fiber diet. So colorectal cancer, most malignancies, just like in other parts of the digestive system, develop from adenomatous polyps. So getting diagnostic colonoscopies can detect polyps early. You have early diagnosis. Cancer in the colorectal cancer primarily occurs in persons older than 50 years. Risk factors include familial multiple polyposis, which means you have a familial or genetic tendency to developing polyps. Long-term ulcerative colitis because it breaks down the tissues. Genetic factors, you just have a predisposition to it, and environmental factors like a diet low in fiber. It makes you all just want to go have a flax muffin, doesn't it? Flax muffins are delicious, by the way. I just made some. Signs and symptoms are largely going to depend on the location of the growth. Generally, though, change in bowel habits like alternating diarrhea and constipation, bleeding, fatigue, weight loss, and anemia. It's usually treated with surgical removal with radiation or chemotherapy. Like other digestive system cancers, it's often detected late because the signs are mild, depending on where the growth is. So here's some common areas for growths and the symptoms that are associated with them. Intestinal obstructions, their lack of movement of intestinal contents through the intestine. It's more common in the small intestine because the small intestine is smaller, right? Mechanical obstructions can result from tumors, adhesions, hernias, or the dreaded other. Functional or adynamic obstructions can result from impairment of peristalsis from spinal cord injury or periatic ileus caused by toxins or electrolyte imbalance. So lots of different reasons for for intestinal obstruction. Gases and fluids accumulate proximal to the blockage, which distends the intestine. And there are increasingly strong contractions of the proximal intestine in an effort to move the contents along. As the pressure increases in the lumen, more secretions enter the intestine, and you get compression of veins in the wall. So the intestinal wall becomes edematous or swollen, and it's preventing absorption of nutrients. So this is a problem. A lot of times people are admitted to the hospital with bowel obstructions, and a lot of times it's treated surgically. Intestinal distension can lead to persistent vomiting. Additional loss of fluid and electrolytes can result in hypovolemia and metabolic acidosis or alkalosis. The intestinal wall can become ischemic and necrotic, and if the obstruction is not removed, you can get gangrene. That sounds awful, doesn't it? Ischemia and necrosis cause decreased innervation with cessation of peristalsis. Paralytic ileus can occur if it's not the original cause. It can occur later as a result of it. So here's another opportunity for those opportunistic pathogens. Rapid reproduction of intestinal bacteria, and some bacteria produce endotoxins. The affected wall becomes necrotic and more permeable, and the bacteria and toxins can leak into the peritoneal cavity, causing, you guessed it, peritonitis, and also into the blood causing bacteremia or septicemia. Perforation of the necrotic segments can occur, and that can cause peritonitis again and septic shock. So a bowel obstruction is a serious thing. It needs to be, a lot of times people are admitted to the hospital for bowel obstructions. Functional obstructions or paralytic ileus can happen after abdominal surgery, spinal shock following spinal cord injuries, inflammation related to severe ischemia, pancreatitis, peritonitis, and infection, hypokalemia, mesenteric thrombosis. Any kind of thrombosis is going to cause ischemia, potentially, and toxemia. So lots of things can cause functional obstructions. Mechanical obstructions can be from adhesions that twist or constrict the intestine, hernias, strangulated hernias in particular, strictures caused by scar tissue, masses like tumors or swallowing of foreign bodies, intussusception, which is where part of the intestine folds into the section next to it, a volvulus, which is a twisting of the bowel on itself. There's a thing called Hirschsprung's disease, where all or part of large intestine have no ganglion cells, so they can't function. So you get decreased motility because of that, and a potential for obstruction. And you can get gradual obstruction from chronic inflammatory conditions. So lots of things can cause it, and it's a serious problem. Mechanical obstruction of the small intestine can result from severe colicky abdominal pain, and sometimes you can hear intermittent bowel sounds. Paralytic ileus, in paralytic ileus, the pain is steady and the bowel sounds decrease or absent. Vomiting and abdominal distension are often the symptoms that send people in to the emergency room with an obstruction of the small intestine. The vomiting is recurrent and eventually with bile-stained content because you run out of stomach contents. The obstruction of the small intestine is a medical emergency. You need to go right in, and they will admit you to the hospital. So if you are working with a patient and they tell you about some of these signs, usually if you're an outpatient and somebody has recurrent vomiting, they're going to cancel their appointment. But if they call and cancel, you can recommend that they go into the emergency room. The obstruction of the large intestine usually develops slowly with mild signs. Small intestine obstructions happen faster because it's smaller. A lot of times constipation results from large intestine obstruction, mild abdominal pain followed by abdominal distension, and then it progresses to anorexia, vomiting, and more severe pain. Usually it's treated by treatment of the underlying cause, fluid and electrolyte replacement, and potentially surgery and antimicrobial therapy. Peritonitis. So a lot of those things that we talked about earlier can result in peritonitis. It's inflammation of the peritoneal membranes. Chemical peritonitis can result from Enzymes released with pancreatitis because the pancreas is not encapsulated. Those enzymes can get loose. Urine leaking from a ruptured bladder, chyme spilled from a perforated ulcer, bile escaping from a ruptured gallbladder, blood, or any other foreign material that gets into the cavity somehow. So basically, chemical peritonitis results from stuff being where it's not supposed to be, right? You get things that are supposed to be encapsulated in an organ that get out into the peritoneal cavity. Bacterial peritonitis can be caused by direct trauma affecting the intestine. So you get gored by a deer and the intestine is affected and you have foreign matter in there. It can be caused by, I don't know why I picked gored by a deer, but maybe you're running with the bulls in Pamplona and you get gored by a bull. You have a ruptured appendix. We talked about that. Intestinal obstruction and gangrene can cause bacterial peritonitis. Any abdominal surgery, if foreign material is left in or infection develops just because of what happened during the surgery. And pelvic inflammatory disease in women, where infection reaches the peritoneal cavity through the fallopian tubes. So, signs and symptoms of peritonitis: sudden, severe, generalized abdominal pain, localized tenderness at the site of an underlying problem, vomiting is common, abdominal distension is common, dehydration, hypovolemia, and low blood pressure, decreased blood pressure, tachycardia, fever, and leukocytosis. The treatment, again, depends on the primary cause, and surgery might be required. Massive antimicrobial drugs specific to the causative organism. So peritonitis can kill you, and it can be hard to localize as well. So another one of the nifty little flow charts from the book with development of peritonitis.